Greetings, everyone, and welcome to today's Institute of Coaching webinar on mental health literacy, what coaches need to know. My name is Jeff Hull. I'm the Director of Education and Business Development at the Institute of Coaching, and I am really excited and grateful to have Dr. Shelley Carson as our guest presenter today, and the Institute of Coaching's Executive Director, Margaret Moore, also as a moderator. Before we get started, let me just share with you a few housekeeping details. We will be welcoming you to send questions in during the webinar. We recommend that because we have a very high number of people on the call that you send the questions through the chat function, and we'll collect them, and at various points along the way, I will pass them on to Shelley and to Margaret to attend to as many as we can get through during the session. Also be aware that I am muting all the audio in order to avoid background noise. If we do find people that are having trouble with their sound, you can feel free to send a chat message to me and communicate with me directly about that. As a reminder, this webinar is being recorded and will be available online in approximately 1 week. All the teleclass and webinar recordings of the Institute of Coaching are located in the podcast section of the library on the Institute of Coaching website. Finally, we will be sending out a survey after the webinar and would appreciate it if everyone could complete the survey. You will need to complete the survey if you'd like to receive any CEUs for attending this webinar. So now I'd like to hand it over to Margaret, who will introduce Shelley and take us away. Hi, Margaret.
Hello, Jeff. Why, nice thought. Take us away. So, in fact, it's Shelley that's going to take us away. And away today is a journey into understanding more about mental health issues. And this is a big topic that is generally in the coaching industry is addressed in a very inadequate fashion, given that so many people and coaching clients in particular do struggle with mental health issues. So we're very fortunate today to have with us Shelley Carson. And Shelley has a number of interests as a neuropsychologist. You may know of her in her work on creativity, on Your Creative Brain. But she's also a lecturer and an expert in mental health issues and is an author of one book in a series that Harvard Health Books published, which is with Hazelden, which is called the Almost series. And it's about various mental health issues on the continuum, on the almost condition. So almost depressed, almost alcoholic, that sort of thing. And this book series is a wonderful resource. It's featured in our masterclass this month. And so we asked Shelley if she could take us on a tour today, clearly just an overview on what coaches should know about mental health. So over to you to take us away, Shelley.
Thank you, Margaret. Hi, everyone. Well, it's a pleasure to be here talking to you today. And it's a little bit daunting to try to cover mental health issues in 75 minutes. So obviously, we'll only be scratching the surface here. But let's take a look. When we think about coaching versus therapy, we have to look at the entire mental health continuum. And here's a slide that demonstrates it. Primarily, coaches look at the part of the continuum that exists from normal mental health to the self-actualized area. In other words, coaches help clients see and achieve their highest potential. On the other hand, therapy addresses the lower portion of the mental health continuum, the part that's devoted to mental disorders. And they are basically trying to fix their clients. So fixing versus helping clients see and achieve their highest potential. And obviously there is a little bit of overlap, as you see in that gray area. But primarily what we believe is that coaches, even if you're trained in therapy, you should decide which you're going to do, coaching or therapy. Coaching, the coach or the couch, as we often call it. Now, there are some people that believe that the mental health continuum is actually two separate dimensions, one for mental health and one for mental illness or disorder. So as you can see in this diagram, the high side of mental health would be flourishing, the low side of mental health would be languishing. The high side of mental disorder would be to have multiple disorders, and the low side would be to have no disorders. Are these two, in fact, actually separate dimensions? In other words, is it possible to have a mental disorder and also be high in mental health, which would be the upper left quadrant of this diagram? And my suggestion to you is this is possible. And this diagram, by the way, was suggested by Corey Keyes from Emory University in a 2003 paper that some of you may be familiar with. Anyway, I'll give you a brief example of a student that I had that I was teaching at Harvard. This was a very intelligent, high-functioning student, but unfortunately she suffered from bipolar disorder. And when she had manic episodes, oh my goodness, she saw devils in the faces of her roommates. She had to hold her hands beside her eyes so that she didn't see anyone out of the corner of her eye, because she had hallucinations when she looked out of the corners of her eyes. And when she had depressive episodes, she would be in bed for weeks at a time, literally, without getting out. So it's very difficult to see how this person could be high in mental disorder, which she clearly was, and also high in mental health. But actually, she had been working with a coach, and the coach helped her to take full advantage of the interim periods when she was in relatively stable health, and to do most of her work then. And then when her episodes came upon her, to be able to recognize them early enough that she could go in and get extra help, and also not to let those episodes totally derail her and totally make her feel bad about herself. So what I saw there was a person, even though she was mentally disordered, she did have a fairly high level of mental health and was able to flourish in spite of her disorder. So perhaps we will think of mental health and mental disorder as being separate dimensions, but also it's important to keep in mind the mental health continuum I showed you earlier, where half of it is devoted to therapy and half of it to coaching. So why is it important for coaches to be literate in mental health issues? And one reason is that a substantial number of clients have mental illness. In Tony Grant's 2007 article, he reviewed a number of studies that looked at coaching and the number of mental health issues, or the number of clients they had with mental health issues. And it ranged anywhere from 4.6% of clients all the way up to 52% of clients. So what we saw was approximately 30% of clients may have mental illness. That means that you as coaches are definitely going to run across some clients that have mental health issues. Now, if you don't know anything about mental health, if you are not literate in mental disorders and mental health issues, then one of the big problems that will happen with your client is your client will fail to make progress. So no progress on the part of the client, and this will also be very frustrating to you. In fact, clients may even regress somewhat in their coaching issues if they're trying to deal with mental health problems at the same time. A second problem, if you are not, as a coach, literate in mental health, is that your client will have a delay in receiving the proper treatment they need. We know that there are a number of people who will come to coaches and try to fix themselves through coaching when actually what they need is therapy. So if you're unable to recognize these signs and symptoms, then this person may experience a delay in getting to the help they need. And there's several problems with that. The first one is we know that the longer people delay getting help when they have a mental disorder, the more severe the outcome is and the more difficult the problem is to treat. There's also some risks for the coach if the coach isn't aware of mental health issues. The first is that your coaching efforts will simply fail with an individual that has mental health problems unless you're aware of them, unless they are being addressed. And when you fail with an individual, it could lead to bad reviews. It could lead to decreases in your own self-confidence in your ability to coach. There may be possible legal issues as well, depending on the situation. If you do not refer somebody who obviously needs mental health for mental health help. And finally, in a very, very rare number of cases, there may even be a possible risk of danger to the coach. So our suggestion is that as coaches, you become literate in mental health, and that this will lead to the best results for your client and for yourself. We also recommend that for coaches who are trained in therapy, again, choose to do one but not both. If you're coaching a client who clearly has mental health issues, offer to refer them to someone else to assist with their mental disorder issues. So one of the questions that we're asked is, should coaches actually screen for mental disorders when they first begin treating or dealing with a client? And I was wondering how those of you out that are listening here felt about this. Do any of you screen for mental disorders? So please write in and let us know, and we'll discuss those going forward. I say there are benefits to doing both. A very short screen for mental disorders that asks, have you ever experienced coaching, mentoring, or therapy in the past, might be a good way to begin the screen. Does anyone have any questions that we should address at this point? Okay, well, let's carry on then. The next thing we want to talk about is what exactly is a mental disorder. A mental disorder is a dysregulation of mood, thought, and or behavior that involves significant distress or inability to function in important areas of living. And those areas of living primarily include your work life. So if your dysregulation makes it impossible for you to do your work, or your personal life, if you're unable to carry on a significant relationship with other people, if you're unable to care for your children or to care for your home, things like this would be serious dysregulation. Therapists often look at what we call the 4 Ds to determine whether a mood, thought, or behavior does in fact constitute a mental disorder. And the 4 Ds include deviance, distress, dysfunction, and danger. And these are things that we use to determine whether disorders belong in the Bible of mental disorders, which I'm sure most of you know is the DSM, Diagnostic and Statistical Manual of Mental Disorders. We're currently in the 5th revision or 5th edition, which is called DSM-5. So let's look again at the 4 Ds. Deviance means simply that you deviate from the norm. So deviation is often found in mental disorder when behavior deviates, when thoughts or when moods substantially deviate from what's expected in a particular situation. However, deviance does not by itself constitute a mental disorder. All you have to do is think of somebody like Tiger Woods or Albert Einstein. Both of them deviated from the norm in their work life, but we certainly wouldn't consider them disordered. So deviance is one necessary but not sufficient reason to diagnose mental disorder. A second is distress. Distress usually accompanies mental disorder, And if the distress is severe enough, then we may diagnose a clinical disorder. Distress, however, is not enough solely to constitute a mental disorder because, as we all know, many things are distressing. Losing a loved one is extremely distressing, but a person who is in grief would not necessarily be considered to have a mental disorder. The third D is dysfunction. And we've already talked a little bit about how important functioning in the areas of your work life and your personal life is to mental health. So if you're unable to function in these areas, then this would constitute dysfunction, which also is a part of mental disorder. However, again, dysfunction alone is not enough to diagnose mental disorder, because certainly if you break your leg, you may be dysfunctional. You may not be able to complete your work activities, or if you have a head injury, but that doesn't necessarily mean you have mental disorder. And then the fourth D is danger. If a person is a danger to themselves or others, this may be a component of mental disorder. So these are the four Ds, and basically what therapists do is they look at the four of them, and they also assess the frequency, severity, and duration of each of the four Ds to determine whether a mental disorder, whether dysregulation qualifies as a mental disorder. And again, please feel free to ask any questions as we go forward.
Shelley?
Now, yes.
Yes, sorry to interrupt you, but while you were speaking, we did get a number of comments that came in around the theme of doing an intake question or a diagnosis. And maybe you could comment. I mean, it was kind of all over the map, but thank you for the folks that wrote in. A number of folks mentioned doing something informal, being a little concerned if they're not a therapist about doing an intake that might confuse a client, or doing a simple questionnaire about medications or history with therapy. In some form of informal designation of determining the direction to take the engagement. I'm wondering if you could maybe comment on that.
Yes, I'd be happy to comment on that. I definitely think that an informal question to begin with is the way to go. So again, the question that we are recommending is, have you had any coaching, consulting, or therapy in the past? So just as a question to find out what kind of interaction this individual may have had with people in the mental wellness and the mental health population. And if they answer to the affirmative about therapy, then you can gently probe a little further. Can you tell me a little bit more about that? What is that? Is it recent? Are you currently in therapy? And without being invasive. Some people are more invasive and they want to know exactly what medications you're on before they agree to coach. So I think a lot of that depends on your coaching style and also the area of coaching in which you're working. So if you're working in health and wellness coaching, I think it makes more sense to be more direct and have a more formal type of screening. If you're working in the executive field or some other professional area, you may want to approach it a little more gently. I don't know if that answers questions. Please follow up if you want more information on that.
So this is Marilyn Edelson.
Oh, and, Marilyn, you're there.
I am here. I was actually muted. So I'm both a practicing therapist and a practicing coach of 15 years. And what I do generally is try to screen on the initial phone call about the reason for coaching. And if I hear something that sounds like, well, you know, I want to deal with my career, but I'm also depressed, then I will see that person as a therapist. But if I'm seeing someone in coaching, and the clarification for me is that there's no medically necessary indication from my initial phone call, and I do my own mini intake, maybe 20 minutes to a half hour in that initial phone call, I will not ask any questions about medication. That's something that, there are many people who take medication of various different sorts who are perfectly well functioning. And I'm, just concerned about the edge where people have severe psychological problems. But if we're talking about the worried well and they're clearly focused on what they want, that's not an area that I will tend to explore if it's clear that they are a coaching client. So just wanted to make that comment.
Thank you. Okay, so we've talked a little bit about how mental disorders, how we decide what actually constitutes a mental disorder. And by the way, for those of you who are not therapists, all mental disorders are listed in the DSM. And if you are going to receive third-party payment for being treated for a mental disorder, you'll have to have one of those diagnoses, which is much different, of course, with coaching. So one of the things that Harvard Medical School has been concerned about is the fact that mental disorders are currently diagnosed categorically. That means either you have a disorder or you don't. Either you cross the threshold or you don't. However, what we know is that many clients and many people in the general population who have only subclinical symptoms can still be very negatively affected by these symptoms. So the Harvard Medical School, a set of us got together and developed a model called the almost effect. And that basically looks at symptoms of mental disorders on a continuum, from normal feelings and behaviors to conditions that meet diagnostic criteria for full-blown pathology. And in that gray area in the middle, we find what we call the almost effect. In particular, I am concerned about depression on a subclinical basis. And so the book that I wrote with Jefferson Prince is called Almost Depressed. And we talk a lot about this gray area that doesn't quite meet diagnostic criteria for full-blown pathology, but nevertheless needs to be addressed. I did a study last year along with Julie Silver and Jefferson Prince from the medical school. And we looked at people with subclinical depression and what their quality of life was like. And what we found was that people who had subclinical depression had a lower quality of life than those with no depression issues, which would be understandable. But we found that they were having even worse relationships in their marriages than people who were met criteria for full-blown depression did. We also found that they had less job satisfaction and that they also felt they had less control over their lives than people with no depression symptoms. So the bottom line here is that people with subclinical symptoms of mental disorder may still be suffering, and they may also not be performing at their peak. So we describe it as an 8-cylinder car that's only operating on 4 cylinders. You'll still get down the street, but you won't really do it in style. So I just want to point out that as we look at some of the mental disorders going forward here, I'll point out both clinically important symptoms and some of the symptoms that are subclinical that may help you have an indication if somebody is starting to experience a mental disorder, in which case, as a coach, you may be able to help them by bolstering their mental health skills. So do we have any questions now about how mental disorders are diagnosed or about the almost effect? I'll wait just a minute and see if there's any questions. Why don't we go forward then and look at some signs and symptoms of disorders that you may encounter in clients. And of course, we can't look at all the disorders today because there's over 300 of them. But I picked several that I think are very important for you to know about because the disorders are fairly common and you may well encounter them in your coaching practice. So let's look first at anxiety disorders. The anxiety disorders that are listed in the DSM include panic disorder, agoraphobia, social anxiety disorder, specific phobia, and generalized anxiety disorder. And I like to describe anxiety disorders as the fear system gone wrong. Everyone has a fear system. It's built into your brain, and it's very important to experience fear. Evolutionarily, species and individuals who are able to experience fear have a better chance of survival. And if you think about that, you can understand why. So because we have these fear systems built into our brain from actually very early in evolutionary times, the chances are that some of those fear systems are going to be hypersensitive and some will be less sensitive in individuals. Individuals with a more hypersensitive fear system are more likely to experience anxiety disorders. Panic disorder is not just having panic attacks. Panic disorder is the fear of having panic attacks or panic-like symptoms. And a related disorder, agoraphobia, is a fear of going someplace or being in a situation in which you might experience panic attacks or panic-like symptoms. Panic attacks include a hyperactivation of the autonomic nervous system so that your heart rate gets really high, your blood pressure skyrockets, and you feel sweaty palms, you feel a lump in your throat, you feel butterflies in your stomach, and your knees are knocking. And this is a very scary feeling. Sometimes people will feel dizzy, sometimes they will feel flushed and overheated, and very often people who are having a panic attack believe they're dying. They believe either they're having a heart attack or that they're having a stroke or some other catastrophic event. And they also may be afraid that they're losing it or going crazy. So panic attacks are very unpleasant. However, they're fairly common. Maybe as much as 15% of the population admits to having had a panic attack. But panic disorder is the fear of having a panic attack. So what you want to do, what you start doing is avoiding places that you associate with having had panic attacks in the past. And gradually your world gets smaller and smaller as fear generalizes and you stop going any place that's associated with the possibility of having a panic attack. Social anxiety disorder is a fear of being judged negatively by other people. Some people have such severe social anxiety disorder that they experience extreme distress, perhaps even panic attacks, whenever they meet someone new. You probably won't have anybody that severe in coaching. However, you may have somebody with a more specific type of social anxiety disorder in which they're afraid of performance in some way, afraid of public speaking, afraid of performing musically or on stage. And of course, if that's part of their profession, then this can be a very serious problem. But this is something that you might see in coaching. Specific phobias are well known: fear of heights, fear of flying, fear of snakes or spiders. And then generalized anxiety disorder is just a heightened anxiety that becomes so strong that it really interferes with your ability to do your work or to have relationships. So here are some signs to watch for in your coaching profession. Clients that feel nervous, anxious, or on edge for an extended period of time. A client that has regular panic attacks, either cued. Acute panic attack is when you know one's coming if you're in a particular situation, or uncued panic attacks, you have no idea when or where they're going to strike. A client that has difficulty controlling their worry, or a client that worries about almost everything. In other words, their worry isn't confined to something appropriate, such as fear of losing their job, but they worry simply about every aspect of their life. Having a client who's unable to relax or is restless and can't sit still. Again, this is due to hyperactivation of the autonomic nervous system. And people who are experiencing anxiety, that fight or flight autonomic nervous system activation calms down somewhat, but it never fully resolves itself. So consequently, the individuals will have cortisol flowing through, unusual levels of cortisol flowing through their bloodstream and their brains. And this can actually damage parts of the brain, especially the hippocampus, which is very important in memory and learning. So we want people to get treatment for anxiety disorders so that they can re-regulate the autonomic nervous system and what's called an HPA axis, which is actually the stress system of the brain. A person who becomes easily annoyed or irritable, and again, if the sign that you would want to watch for is a change in their irritability. Some people are just naturally irritable, but if you notice a change in a client's annoyance or irritability level, that's something to take note of. A client that feels something awful might happen. So there's always this feeling hanging over them that something isn't quite right, that something is going wrong. And finally, a client who avoids people, places, or situations that can cause anxiety. So all of these things are important for you to watch for. And when should you make a referral? Should make a referral when anxiety, irritability, or worry interferes with the client's ability to function at work or to have meaningful relationships. You should also refer when a client begins avoiding situations that may affect their work or their social relationships. So again, fear tends to generalize. That is, it kind of spreads in bigger and bigger concentric circles so that more and more situations become feared if they're not treated. Finally, you should refer if you observe that anxiety is actually increasing or generalizing. Marilyn, you're on the line. Would you like to add anything to the anxiety here?
Well, since coaching is often structured around goals, if the response to the idea of setting up goals increases the client's anxiety, that again would be something to be concerned about.
Okay, thank you.
Because again, just to elaborate a little bit, the anxiety might be around performing for the coach or pleasing the coach. And so these are all markers of distress that if the client is responding to the coach in that situation, what is it like for them on the job? What is it like for them with their family when other people have expectations?
Okay, thank you.
Shelley, this might be a good time that we are getting a few questions that are relevant, I think, to what you're talking about.
Excellent, thanks.
And Margaret seems to have disappeared. So maybe I could go ahead and share with you a couple of these questions. There's 2 or 3 questions coming in related to the potential for working with someone as a coach who either has an ongoing therapy engagement or may need a referral. And a couple of people are asking about coordinating with a therapist as opposed to just referring to a therapist, so that there's like a 3-party dynamic. Maybe you could comment on that.
Okay, thank you. Yes, I actually do plan to talk a little bit about this later on.
Okay.
There are absolutely excellent roles for coaches for clients who are being treated for mental disorder. So as in the case of the student that I mentioned earlier, she was seeing a coach as well as being treated by a psychiatrist for bipolar disorder. And that was extremely beneficial to her and allowed her to live a somewhat normal life despite having a highly debilitating mental illness. So thank you for those comments, those of you who made those. And we'll discuss it a little more in a few minutes. Okay, let's look at depression now. Depression is an area that particularly concerns me because it seems that we're almost in the midst of a depression epidemic right now. The World Health Organization says that right now depression is the second most debilitating illness in the world, and they anticipate that it will be the first most debilitating illness by the year 2020. So depression seems to be increasing not only in the United States but worldwide. And another very distressing aspect is that the age of onset of depression appears to be getting younger and younger. So now it's so sad to say we have 2% of our children who are in grade school who've actually experienced a major depressive episode. That's 1 out of every 50 children, or 1 in every 2 classrooms. And that's pretty scary. Now, the seriousness of depression, of course, it's extremely distressing to the person who has it, but people around them also suffer. So if you have a family member with depression, then you'll know what I mean, that depression almost has a contagious aspect to it, and it's distressing for family members, friends, and co-workers of an individual with depression. One of the reasons we would like to see depression stopped before it reaches the full-blown clinical stage is that it's quite a dangerous illness. Clearly, there's the possibility of suicide, and the risk of suicide is increased somewhere between 9 and 15 times that of a person who is not depressed. Another statistic about depression is that people who are depressed are 4 times at greater risk for having a heart attack. And finally, when you allow a full-blown depressive episode to continue, it actually makes substantial changes in the wiring of the brain that make it more likely that a person will have a future episode of depression. So the earlier we can catch a depressive episode, the better the outcome for the individual. These are the main symptoms of depression. They include depressed mood or anhedonia. Anhedonia comes from hedon, pleasure, and not pleasure. So anhedonia means a lack of pleasure. And people who are depressed report an inability to experience pleasure, and they find little pleasure in things that used to make them happy. So depressed mood or anhedonia, changes in body weight, either unintended increases or decreases in body weight, changes in sleeping patterns. Depressed people will either be unable to sleep and have insomnia, or they will sleep a lot longer than normal and not get out of bed. This is called hypersomnia. There may be changes in psychomotor speed, so you may notice that the depressed person talks much more slowly and moves more slowly, or you may find that they move much more rapidly and they have a lot of non-goal directed hand movements, and they can't sit still. Difficulty concentrating, a constant feeling that they have no energy, and excessive guilt over things that they really shouldn't feel guilty about. And then finally, thoughts of death or suicide, of course, are terrible indicators of mental distress and disorder. And the statistics say that 80% of people who complete suicides have a history of depression. So depression is very much associated with thoughts of death and suicide. Now, there are signs that you can look for in clients, because very often what happens is people who are going into an episode of depression aren't able to see it for themselves. So it's very important that people who are around them are able to interpret signs of depression. And so what we would be looking for here are actual changes in the person's behavior and demeanor. If they become more easily frustrated, if they start withdrawing socially, that's a very big sign. Appetite changes. One of the things that people who are becoming depressed say is nothing tastes good, or they complain about the way everything tastes. If they appear to be stressed out and they want to stop the world and get off, that's another sign. An additional sign is that their sense of humor seems to have gone to sleep. They don't find things funny, and they may even complain about things that they used to find funny that they think are really stupid now. They don't enjoy previously enjoyable activities. Again, that's anhedonia. They're easily irritated, and they just want to be left alone. Just leave me alone. But then they will also simultaneously seek reassurance from others. And finally, a very bad sign is when people start giving away cherished belongings. Again, this is one potential sign of suicidal thoughts, so you should be very much aware of this. So these are signs to look for. And when you see signs like this, one of the things you can do is ask people how they're feeling and try to get them to open up to you and let you know if something's really bothering them or if they're starting to really slip. You should refer if you find that several of the symptoms or signs that we've looked at have persisted for more than 2 weeks. So it's normal for people to have ups and downs, ebbs and flows in their emotions. But when those downs start lasting for several weeks at a time, that's when a potential depressive episode is occurring. If low mood or anhedonia is interfering with the ability to work or have meaningful relationships, if the client is purposely isolating themselves, socially withdrawing, if you observe that any symptom is getting worse, or, of course, if there's any mention of suicidal thoughts. When people talk to you, if you ask them, and it's perfectly fine to ask somebody if they are contemplating suicide, but don't offer confidentiality, because if somebody is contemplating suicide, you need to let a mental health professional know right away. So these are times when you should refer a person who you see having signs of depressive symptoms. Now, Marilyn is actually assisting on this webinar. And Marilyn, I was wondering if you could address how people could do a referral. What is the actual process?
Okay. Well, there are a few other subtleties about depression, major depression, minor depression, biological depression, non-biological depression, that would require another webinar, I think. But in terms of making a referral, the fallback is always go to your local emergency room. However, if the individual is not in an acute state of suicidality, if they have family around, in other words, they're not isolated, then you can take a little bit of time and help them either go through their insurance. A variety of different professional organizations have referral networks. The National Association of Social Workers is one. They have a hotline where you can get names of therapists by insurance and location, and also specialty. The Psychological Association may have something similar to that. Various different groups, Lawyers Concerned for Lawyers, there's the physicians group, various different professional groups. They also have their own referral networks. But the fallback is always go to your local emergency room. And that's actually a message that most therapists are required to put on their phone numbers, so that if they are not available to their own patients or to a new patient calling, that kind of signals the action that the individual can take. As a coach, if I have a client that I'm concerned about, I'm also interested in referring to therapists who are sympathetic to coaching. And there are probably two categories out there of therapists, some who understand what coaching is and are happy to be collaborative and work together with you. And then there are others who are kind of violently opposed to coaching, primarily, they say, because there are non-licensed people who are operating in this profession. So I try to keep a roster of colleagues that I know are positively oriented towards coaching, and then the question is whether the patient, whether the coaching can continue. In some cases it can continue during a period of time where they're also in therapy, and in other cases the person may need a course of therapy and then to come back for the coaching. The other piece of it is that there can be if you think in terms of cognitively, that coaches can be instrumental in helping a client become more positive, but you don't, when you hear some of the more serious symptoms that the ones that Shelley is talking about, better safe than sorry, I would still always refer to a therapist while you're continuing to work with the individual, if it's appropriate, on more positive attitudes. So sometimes that involves helping them with perspective, using various different coaching tools that can help shift them out of the mental state. But as I said, I would rather be safe than sorry.
Thank you. Thanks, Marilyn. So yes, I think it's very important for coaches to ask around in your community and try to get a list of therapists that are effective and that have specific specialties. Some people specialize in anxiety disorders, some in eating disorders. And so if you have a list that you can easily refer to, that will be very beneficial for you as well. So let's look at eating disorders now. The eating disorders that are listed in the Diagnostic and Statistical Manual include anorexia nervosa, bulimia nervosa, and binge eating disorder. And we talked about how dangerous depression can be. So that's why you don't want to fool around with it. You want to refer when you see the signs and symptoms that we discussed. However, the most serious, the most deadly of all psychiatric disorders turns out to be anorexia. And the reason for that is when people get below a certain body weight, they have heart problems, they have problems with virtually all of their organs. Even their brains are smaller, their brains shrink. Now sometimes that may be, researchers aren't certain now, but it possibly is because of dehydration in the cells of the brain. And some of that brain mass is regained if you can get the individual to gain weight. But anorexia is the most deadly of all psychiatric disorders, and the lifetime risk for death is around 20%. So this is nothing to fool around with. This is something that you definitely need to find an expert in eating disorders to assist a client who you suspect may be anorexic. Here are the symptoms, the criteria for diagnosing eating disorders. And we won't look at binge eating disorder because basically the criteria for binge eating disorder is that you binge. But anorexia is a refusal to maintain a body weight. Typically, we're looking at somebody who refuses to maintain a body weight of about 85% of that which is recommended for their height. So once the body weight gets below that, all kinds of systems start shutting down, and with a very low BMI, there's heart difficulties, there are pulmonary difficulties, there are all kinds of difficulties. The second criterion is an intense fear of gaining weight or fear of fat. And the final is a distortion of body image. So the person who is very, very thin due to anorexia may see themselves as being fat. Their image of their own body is distorted. Bulimia nervosa includes recurrent episodes of binge eating that are followed by compensatory behaviors such as purging. Purging can be vomiting. It can be also excessive use of laxatives and diuretics. And compensatory behaviors can also include periods of starvation or periods of excessive exercise. So again, the person with bulimia is binging and then purging or using some other compensatory behavior at least once a week. And their self-evaluation is based on their body shape. In other words, their self-worth is determined for them by the way they look. Signs to watch for.
Can I just comment on the binge eating?
Certainly.
That I think people underestimate what binge eating and eating disorders is. It could be 6 quarts of ice cream, 3 loaves of bread, 5 bags of chips. It's far in excess of what most of us think of as binge eating. So I just wanted to make that comment.
Right. So I agree with you. I think we overuse the word binge eating in normal parlance.
Mm-hmm.
We go around saying, "Oh, I binged. I ate 4 cookies." Well, that isn't exactly what we mean by binging. Binging is truly eating a very large amount of food in a small period of time. So here are some signs to watch for with anorexia. Even though we discussed the fact that clients seem to have a distorted body image, somewhere in their brain they must realize that they look thin to other people, because they will often wear baggy clothes or puffy clothes to mask their thinness. Dry, cracked, or yellow skin, especially on the palms, is another thing to look for. flesh that feels cold to the touch, because hypothermia is one of the symptoms of anorexia. There also may be hair loss or brittle hair, and at the same time, this fine downy hair, which is called lanugo, starts to grow, all over the body. And one of the reasons for this is it's to help keep in the heat because of the hypothermia that's associated with anorexia. Anorexia is also associated with a high level of perfectionism, or sometimes the anorexic person may be what we'd call a control freak. They're trying to maintain abnormal control of their life. And the client may also voice concern about being fat when clearly they're not. So these are some anorexic signs to watch for. Bulimia also has some signs. One sign is calluses on the back of the hand. This is called Russell's sign. And this comes from inserting the hand into the throat in order to cause vomiting or purging. There's also erosion of tooth enamel, and we'll often see this in very, very young girls because the stomach fluids are eroding tooth enamel. Salivary gland enlargement gives the cheeks kind of a square or puffy or chipmunky look to them. And then another sign to watch for is an unusual concern about one's body shape. So when to refer? If the client displays any of the signs of anorexia, because again, you don't want to fool around with anorexia. That person needs to get help immediately before there's heart complications. When a client appears to be hiding weight loss, if a client is purposefully purging. We went to dinner, my husband and I, with a couple a few nights ago, and they brought their daughter with them, and she ordered something she didn't like, and so I just said something like, "Oh, I'm sorry you don't like that." And her mother said, "Oh, that doesn't matter. She'll just go home and throw it up anyway." So that led me to believe that there's a substantial percentage of the population that doesn't realize that purging is a serious problem. And it can also generalize it can cause serious health concerns, but it also generalizes to a way of coping in which a person just purges themselves of the problem rather than trying to face it outright. If you believe a client is binging or purging to deal with other mental illness issues, or if a client's weight is becoming an obvious health problem, all of these are times when you should refer. So I'm going to go kind of quickly now through alcohol abuse. I think many of us are pretty familiar with the symptoms of alcoholism. This is the symptoms that are listed in DSM, but the three that are really important are a persistent desire or unsuccessful efforts to cut down, tolerance, which means the person can drink more and more, needs to drink more and more to get the same high or the same effect. And withdrawal means that the person has a particular withdrawal syndrome when they stop drinking. That includes being nauseous, hyperthermic. Actually, withdrawal from alcohol binging is very serious. Here are some alcohol abuse signs to look for in a coaching setting. If the person doesn't function well in the mornings, that could be a sign. If they keep alcohol in their office or briefcase, if they admit to having tried to cut down and failed, if they're late for work or appointments on a regular basis, and again, that in and of itself would not be a sign of alcoholism, but if you see several of these signs falling together, then that's cause for alarm. If they have a DUI record, if you believe that they're using alcohol to control anxiety or other emotions, if they drink during a coaching session or suggest that you go have a drink during the coaching session, if they have memory lapses for important information, if they seem disoriented or have slurred speech, or if they seem preoccupied with thoughts of drinking. So all of these are times when you might want to consider referral. Clearly, when a client is dangerous to themselves or others, if they're going to get behind the wheel of a car, if their drinking is interfering with their ability to work or to have meaningful relationships, if they appear to be drinking as a form of self-medication for other psychiatric problems, or if they're just unable to control their drinking. So the last thing I want to look at are personality disorders. And these are rigid, inflexible, and maladaptive patterns of either inner experience or behavior. A person with a personality disorder may simply appear to be a difficult client. And generally, people with personality disorders do not think there's anything wrong with them. They may not be experiencing any distress. They think it's the rest of the world that has a problem. These are the personality disorders that are listed in DSM-5, and there are a total of 10 of them. Some of them are more likely to show up in coaching sessions than others. And here are some of the personality disorder signs to watch for. Paranoid personality disorder, or something on the paranoid continuum, can really be difficult to deal with in coaching. And the signs you would look for there include hostility, a certain detachment of the of the client, suspiciousness, sorry, my psychopathology training is kicking in, or somebody who holds a grudge, not necessarily against you, but against anybody. These are signs of potential personality disorder. If the person needs to be the center of attention, has problems with authority, feels that they are special or deserve special treatment or have special powers, and if they're very manipulative of you, these are signs of narcissistic personality disorder and are very difficult to work with. If a person is a liar, if they purposefully deceive you or lie, if they display callousness toward other people, if they display no empathy whatsoever over problems they themselves may cause for other people, these are also serious signs of potential antisocial personality disorder or on the psychopath continuum. A person who is emotionally labile, that means their emotions fluctuate. They're happy, they're sad, they're miserable, they're angry, and this fluctuates within an hour session. This is a potential sign of personality disorder, as well as neurotic perfectionism, preoccupation with the rules, fears that you're going to abandon them, or I think, Marilyn, you mentioned earlier about somebody who is trying to please you too hard or is unusually submissive. This is also a potential sign of personality disorder. Or finally, somebody who really latches onto you very quickly and you develop this instant rapport with them and they're your best buddy, that can also be problematic. So when should you refer when you suspect somebody has a personality disorder? Well, clients will likely refuse referral because, again, people with personality disorders think the rest of the world has a problem, not themselves. However, if their personality problems have led to depression or anxiety, they may be more comfortable with psychotherapy. Finally,
Shelley, Margaret here. We've about 10 minutes of, I'd say there's a number of questions that will take about 10 minutes to address, so just if you can bear that in mind.
Very good. Thank you. And finally, we would suggest that you discontinue coaching a person if you feel uneasy or coerced, or that they're eroding your self-confidence. So I want to look very quickly at clients and the role of the coach in mental illness, and then whatever questions we have, we'll be glad to look at. There are three different situations where the role of the coach may come in. The client has an undiagnosed mental illness, the client is currently being treated for mental illness, or the client develops mental illness during coaching. If the client has an undiagnosed mental illness, then your job as a coach, your role as a coach, will be to recognize signs and symptoms and offer a referral to this person. A client who is already being treated for mental illness, the coaching position may offer encouragement and cheerleading and assist with treatment compliance. Sometimes treatment is very difficult and uncomfortable for people who have mental disorders, and coaches can help them to maintain their compliance with treatment. And finally, you have the ability to strengthen their mental health skills. For clients who develop mental illness during coaching, one thing is important is to note changes in the behavior or attitude of the person, recognize signs and symptoms of mental disorders. Again, strengthen mental health skills and offer a referral. So if you're going to continue to work with a patient who is being treated for mental illness, obviously you want to do so in coordination with their therapist. This is just a list of mental health skills that we think are very beneficial in helping protect people against the development of mental disorders. And these are things that coaches are very trained in and able to assist their clients with. So the role here is not only to help your client achieve mental health, but also to protect them from mental disorder. So can we take some questions?
So Shelley, the first question that you haven't covered has to do with clients with executive function issues, you know, ADD, and I want to just first mention that there is a domain, a specialty of coaches who work with ADD particularly, because it's kind of, you know, somewhere in between a mental health issue and a functioning issue. Shelley, do you have any thoughts on that?
Well, I do, and I feel badly that we haven't had time to cover that. Another thing that also really needs to be covered is OCD and post-traumatic stress. So there are several disorders that we did not cover today, and maybe we'll have to do another session in the future. But Margaret, you are absolutely the ADD expert, and so I would defer that to you.
Yeah, so my point there is that there are some very good programs now where you can learn to coach people with ADD, and I don't think it's a good idea to try to do that unless you have some training and special background, because it's a complex situation and there are very specific interventions and issues that people need help with. And let me just say, Shelley, I know you were doing a heroic job to cover a lot in a short hour, and I think that this topic, it deserves more, and we'll do more in the future. So another question has to do with running parallel coaching and therapy and having the coach and therapist, in fact, collaborate. Do you have anything to say about that, or maybe Marilyn might?
Well, just let me put my 2 cents in. I do think that if we consider mental disorder and mental health to be on separate continua, which Corey Keyes had written the article about, and I showed a diagram earlier, that a person may be developing mental health skills at the same time that they are recovering from mental illness. Clearly, there would need to be a collaboration between the therapist and the coach in this regard, because the therapist will know exactly how far a patient or a client can be pushed in this area, and it would definitely be very important for there to be collaboration going on there. I assume that in most states this would, however, require the consent of the client.
Okay, good. Another important question here is if you work by phone and you obviously can't see an eating disorder, some of the signs by observing appearance, do you have any thoughts on how to sense this, discern this in a phone coaching relationship?
Yes, that's a good question. And I know that a lot of coaching does take place over the phone. So one of the things that does seem to come across with many individuals, not all, but many individuals who have eating disorder issues, is that they will bring up food, they will bring up body weight, they will bring up appearance, and they will bring up body weight a little bit more often than you would expect for the client to do. And so you just have to be alert for these types of mentions.
Okay, good.
A lot of their metaphors are food related. I'm being eaten up alive by my job, things like that. Those are often red flags as well.
Okay, good. So is there any danger that a coach could trigger a manic episode?
Okay, do you want to address that, Marilyn, and then I'll say something?
I would say that no more than a friend or the dentist could. If a manic episode is happening, it's a biological disorder, if that's something that's brewing, again, generally manic episodes occur, first episodes usually occur in the 20s. And if you've done a good exploratory, I call it a discovery session in coaching with someone, and you ask them, have you ever had counseling? Have you ever had other coaching? You're going to get, some information that will tip you off about that. And then the question is, okay, is this something that is being treated?
Okay.
And, go ahead.
Okay, I was going to say that there is a slight risk if a person, if in teaching a person, for instance, positivity and really activating positive emotions can sometimes start somebody into a manic episode. Basically, anything that makes them feel good can do this. Sleep deprivation, being in bright sunlight for too long. Obviously, we know that sometimes taking SSRIs or their antidepressants can throw them into manic episodes. Changes in season. So the only concern that the coach would have is, you have to keep an eye on how the person's emotional state is changing. And if it starts to get too positive too quickly, then you might want to help them tamp that down a little bit.
Okay, so our last question has to do with suicidal ideation. And the question is, would the coach ever ask to speak to someone else, a family member or the therapist, when you hear it? This is obviously one of the more complex areas. How far does one go?
The important thing is once the topic of suicide has been brought up, that you don't leave it. You don't just gloss over it. You have to pursue it. If you feel that the person is in danger at the moment, don't leave them alone. You have to, you may have to walk them to an emergency room. Otherwise, what you should do is tell them that this is serious. I'm going to talk to other people about it and ask for permission to speak to their therapist. But you need to address it with somebody. You can't just leave it alone. I don't see any problem with mentioning it to a family member. Again, you are not going to promise confidentiality to this person. As soon as they bring it up, you try to explore it, but don't tell them that you're not going to tell anybody, because you have to. You have to bring it up to somebody else.
Well, thank you, Shelley and Marilyn, for an amazing tour of a very large topic. I think the level of interest tells us that we ought to do more of this. The Institute, as you all know, lives at McLean Hospital, which is the most respected psychiatric institution in the world, and so we certainly have more resources to offer. The masterclass this month is chock full of information. The Almost series books are great resources. And I think that I'd just like to plant a flag, too, in that I think there's a lot of opportunity in the future for combined interventions, combining coaching and therapy. As Shelley mentioned, that there are many things that coaches do which improve mental health, which also can help people be healthier mentally even when they have a mental disorder, which is a very valuable opportunity. Something like 30 or 40% of medical costs are associated with people who have comorbid medical conditions and mental health issues. So it's a huge need in society. So I think way more to come. So thank you, Shelley, for a brilliant tour. Thank you, Marilyn, for jumping in. Thank you, Jeff. Shelley, do you want to add anything before we say goodbye?
I would like just to briefly sum up what we've talked about. First of all, coaches do work on the positive side of the mental health continuum, while therapists work on the negative side. And we think it's important to avoid being both a coach and a therapist simultaneously with the same client. Each mental disorder has a specific set of signs and symptoms, and by familiarizing yourself with these signs, you can help clients get the help they need. Coaches do have a role in preventing mental disorder, and I think it's one of the biggest roles that we have as coaches, and also in improving treatment outcomes. Thank you all.
Can I add one thing to your summary? And I just want to say that Shelley did a brilliant job. I just want to add, as a coach who does not have a mental health background, if you are ever uncomfortable with anything that occurs with a client or that the client tells you and it makes you uneasy, seek a consultation, talk to a colleague, talk to an experienced therapist. Don't keep it to yourself. I've had a lot of non-therapist coaches seek me out once their situation has gotten out of control with the coaching client, and don't ever let it get to that point. At the first sign of discomfort, seek some consultation with someone who knows about the mental health issues.
Thank you, Marilyn. And that reminds me that all of us as coaches are not immune from mental health and mental disorders as well. So the first step is to go get help for ourselves if we need it.
Physician, heal thyself.
Right, good. Okay, thank you all. This has been fabulous for all, and we'll do more on this topic.
Super.
Bye, all.
Bye.
Bye, everyone.
Bye, Shelley. Thank you so much.
Certainly.